just wanted to go through what muting and unmuting looks like. Most everybody who's called in today, except for the presenters, are muted. And so in order to mute yourself and unmute yourself, there's a little red microphone next to your name. We do also have a chat box. If you click the blue icon at the top, you can see the chat, and if you select you can either select host and presenter or all attendees if you have questions, and we do encourage you to ask questions as we go through the presentation. We may pause in between presenters to answer a couple of them, but we'll largely save them until the end. So you are at one of CSH's national HRSA-sponsored webinars. This one's called Stopping the Revolving Door: How Health Centers Can Serve Justice-Involved Populations, and we thank you for coming to our webinar today. For those of you who may not be familiar with CSH, that CSH stands for Corporation for Supportive Housing. We're a national nonprofit focused on advancing housing solutions that improve the lives of vulnerable populations. CSH engages vital public systems to adopt supportive housing, allowing for the shifting of resources and many times broader systems change and cross-sector engagement. Our HRSA Technical Assistance Program includes many things, including webinar series, kind of like learning collaboratives, direct technical assistance, online and in-person trainings, et cetera. Our overall goal is to foster and expand health center collaboration with other health system stakeholders and supportive housing, and to improve healthcare outcomes for homeless and extremely low-income individuals, frequently using multiple crisis systems. We collaborate in almost everything we do in this initiative with the National Healthcare for the Homeless Council, who's also presenting on this webinar today. So I'm excited to announce our discussion leads today. This webinar is a companion to the release of a recent brief we put out, which we'll talk about a little bit more later on. That brief is on the topic of health centers working with justice-involved populations. And we're excited to host, in addition to myself, Kim Keaton, I'm a director with CSH, and Lauren Berner, a project manager with Healthcare for the Homeless Council, 3 folks from the field that can really talk to you in depth about the work that they're doing in their health centers to improve the lives of justice-involved populations, which includes those individuals exiting prison and jail in their communities. So first, after Lauren, we'll have Ann Sinclair, Dr. Ann Sinclair, who's the Transitions Clinic Coordinator at La Clinica de la Raza in North Vallejo, California. She'll be followed by Ann Sinclair, who's a nurse practitioner at Unity Healthcare in Washington, D.C. And then finally, we'll have Terry Craig, who's the Director of Housing First and Act Services from Colorado Coalition for the Homeless. So we really have folks from across the country with us today. So I am going to, we have a lot to talk about today. I'm going to go ahead and turn this over to Lauren Berner from the Healthcare for the Homeless Council, who's going to start us off by talking about the health challenges of justice-involved populations.
Great, thanks, Kim. Hi, everyone. As Kim mentioned, I'm Lauren Berner. I'm a project manager at the National Healthcare for the Homeless Council, and I work really closely with Kim and the team at CSH on the Health and Housing Partnerships work. And I'm just going to talk for a couple of minutes about some of the health challenges facing justice-involved populations to provide some context for some of the other presentations you're going to hear. So I want to start by looking at the physical health concerns folks interacting with the justice system are experiencing. So according to the Bureau of Justice Statistics, between 2011 and 2012, about 40% of folks in jail or prison had at least one chronic health condition, and that's compared to about 30% of the general population at the time. And 24% of folks reported having at least 2 chronic health conditions at some point during their time in jail or prison. The Bureau also found that there was an increase in the prevalence of high blood pressure and diabetes between 2004 and 2012, which is the most recent data we have. They also reported that individuals in jails or prisons are more likely who have ever had a chronic health condition or infectious disease like tuberculosis or hepatitis B and C or HIV. So kind of thinking about how involvement with the justice system plays out in your health long term, not just during your time while in jail or prison. Another study reported similar findings. So that showed that people in prisons have 4 times the rate of active tuberculosis than found in the general population, 9 to 10 times the rate of hepatitis C, 8 to 9 times the rate of HIV infection, 3 times the rate of serious mental illness, and 4 times the rate of substance use disorders. And this was true across jail populations as well, which have similarly elevated levels of prevalence of these different conditions. Relatedly, many people in prisons and jails are living with traumatic brain injury, related problems that can complicate their self-management and treatment while they're incarcerated. And most folks will be released, so those problems and challenges also return to the community, and you're probably seeing folks in your health center as well. The CDC, Center for Disease Control and Prevention, calls traumatic brain injury in prisons and jails an unrecognized problem. And various studies show that between 25 and 87% of inmates report having an experience of head injury or traumatic brain injury. That's compared to 8.5% of the general population. The council collaborated with Dr. Pam Diamond, who's a researcher at the University of Texas in Houston. And her work estimated that the prevalence of traumatic brain injury overall in the offender population was about 60.25%. Again, compared to 8.5% in the general population. So this is a serious health condition that we need to kind of think about how we address. So to go with that, I just wanted to quickly point towards a resource on this topic. The Council is working on a set of adapted clinical guidelines on caring for individuals who are homeless or unstably housed and living with the effects of traumatic brain injury. And this will be available on our website, so you can take a look and think about how you can adapt this to your work and apply that to your work with folks who are interacting with the justice system as well. And then just briefly on the mental health side, the Bureau of Justice Statistics also found a higher prevalence of mental health diagnoses among folks in jail or prison than the general population. About 37% of folks in prison and 44% of those in jail reported a mental health diagnosis, and major depressive disorder was the highest reported condition. People interacting with the justice system were also more likely to meet the threshold criteria for a serious psychological disorder within the past 30 days. And those who are in jails had a higher percentage than those in prison. Also important to note, in light of these disparities, is the fact that only 50% of people reported that they were satisfied with the health services that they were receiving in jails or prisons. And that makes it difficult to engage folks and ensure that their conditions are being managed. And that really impacts the work that health centers do, engaging folks in jails or prisons or those with a history who have been released back into the community. And so just kind of to think through some of that context as our presenters move through their programs today. And I'm going to pass it back to Kim to talk a little bit more about some of the models that we've heard.
Great, thanks, Lauren. HRSA, as our funder for our National Cooperative Agreement, asked CSH and the Healthcare for the Homeless to explore the health and housing needs of justice-involved populations. They are interested in the outcomes for this population in general from a social determinants of health standpoint. And we know that there are lots of issues on both health and the housing side when people are reentering the community. In doing this work, we interviewed several programs across the country and released a paper entitled The Same Thing as This Webinar, Stopping the Revolving Door, which you can find at the link right there. It should be available also on CSH's website, csh.org/HRSA-TA. It was released at the end of June. But first, let's take a step back and just really think about what the impact and relationship between homelessness and incarceration is, and why is it that they have a reciprocal negative impact on each other. So at the top, you really see there's the criminalization of homelessness in many communities, really criminalize much of the things that people experiencing homelessness do outdoors that they may have to do outdoors. And so this leads to repeated arrests and then re-arrests for minor infractions that may grow in increasing in severity over time. The lack of housing reduces the impact of any health care that the individuals have and makes it difficult to, sort of continue any health care, follow up on any health needs they have. Things as simple as keeping medication for diabetes or something like that become incredibly difficult to manage when an individual is homeless. A lack of stable housing increases the likelihood of recidivism. So when somebody's released from jail, if they don't have a home, they're much likelier to be out in the community and, again, be arrested and re-arrested. And then if somebody is released and actually has an opportunity to access housing, there are a lot of barriers thrown up by landlords, sometimes by housing authorities, in terms of accessing housing in the community. And this is really just talking about housing. There's lots of other impacts on, education and employment as well. So there's another sort of aspect to challenges faced by justice-involved populations, and that's in actually accessing health care and health insurance once they're released. So, thousands of people exit jails and prisons every year. Most people who are currently incarcerated will leave at some point during their life. And they're often released with only a small amount of medication, sometimes as little as, just a week or 3 weeks, and no outside care arranged. There's, it's long been a practice by incarceration facilities to terminate health insurance, particularly Medicaid, upon entry to correctional institutions with the idea that health care is provided inside those walls. However, as you heard from Lauren, often that health care is not satisfactory, substandard, and even if it is standard, there's a lot of difficulties with providing health care in an environment where people need to be locked up. So some states and counties have, seeing that people have such a hard time re-entering, re-enrolling in health care after reentry, have started, instead of terminating like a Medicaid, they've entered into a suspension status in order to improve and make that re-enrollment easier after release. This is now seen as a best practice so that re-enrollment and health care coverage can be part of the discharge planning process. This is something that health centers could also help these individuals with. Health centers are really uniquely poised in communities across the country. Sometimes they may even be located near a jail, and they're really, meant to be experts in providing that benefit navigation along with much needed initial health care appointments and medication continuity to ensure a healthy and stable reentry. We're going to talk a little bit more. Our presenters are going to talk a little bit more about some of that work and all the way to helping folks with housing. I just want to do a quick overview of the types of programs you're going to hear about. First, let's see, I think I'll start with the middle example here, coordination upon release, because that's the one you're going to hear about first. So this is really purposeful coordination for inmates upon release for health centers that aren't necessarily inside the jail, like they don't have a clinic inside the jail or anything like that. This type of program might develop relationships with discharge planners at the jail and probation or parole departments so they know a person's needs before release. In the specific example you'll hear about right after I talk and in our publication, La Clinica in North Vallejo, California uses the Transitions Clinic Network model, which is a national model for working with justice-involved populations. And you'll hear about some of the highlights that they use in order to coordinate with a person's needs prior to release. Another example are contracts with the jails to provide health care. And This is an example you'll hear from Ann Sinclair from Unity Healthcare in Washington, D.C., where the health center has a direct contract with the jail to provide health care to inmates. Obviously, this relationship allows for improved continuity of care once the person is released and has an appointment at the health center. Then the health center can really continue to work with the inmate on the broader social determinants of health impacting that person's life. And the third example will be from Denver, and you'll hear from Carrie Craig from the Colorado Coalition for the Homeless. That is really in particular for those people with justice histories that have experienced homelessness, repeated homelessness or long-term homelessness, and are also suffering from other issues such as mental health, substance use, and physical health issues. Health centers can either partner with supportive housing providers or even, as in the case of Denver, provide those services in supportive housing that are potentially billable to Medicaid in large part. And so this would be partnering with a housing authority or other sorts of rental support to pay for someone's rent while the health center is providing support services and supportive housing, or partnering to do so. Because of housing's prominent role as a social determinant of health, it really can be seen as a specific health need in that way. So I am going to go ahead and pass the ball here to Dr. Ann Sinclair in Vallejo, California.
Hello, thanks so much for the introduction, Kim and Lauren. So now that we've talked a lot about the conditions, I'll talk some more specifics about our program at La Clinica in Vallejo. I'm a family doctor at La Clinica, which is a network of federally qualified health centers throughout the Bay Area in the San Francisco Bay Area. And we're located in Vallejo, which is a little bit north of San Francisco. And I'm the clinic coordinator for our Transitions Clinic program there. So I'll talk a little bit about the Transitions Clinic model. It was developed both here in the Bay Area in San Francisco and in New Haven, Connecticut. And the idea is that we want to provide a medical home for prisoners when they're returning to the community. So folks with chronic medical conditions, when they come out, will have a medical home. Transitions clinics are based within community health centers in areas that are most impacted by incarceration. And the really key ingredient to the Transitions Clinic model is that we employ community health workers who themselves have a history of incarceration, so they're able to relate with our patients on a peer basis. And their role is to connect patients with health and social services through education, outreach, and advocacy. So we're not just providing standard primary care services, but we're also able to really work with the social determinants of health through the work of our community health workers, connecting folks with resources in the community. So an overview of our clinic specifically, La Clinica de la Raza, the organization that I work for, really comes from strong roots in immigrant communities living in poverty. It was started in Oakland, California, and has strong roots in the Latino community there. But we've been serving here in Vallejo for about 15 years, and we have a very diverse community here. It's about 25% Latino, 25% African American, 25% Caucasian, and 25% Asian. So it's one of the most diverse populations in the country. At La Clinica, we're actually the only community health center in Vallejo. And unfortunately, it's a place that's deeply impacted by incarceration. Vallejo is a primarily working class community. The city actually declared bankruptcy about 10 or 15 years ago, so it's continually been very under-resourced. It's difficult for folks to find employment here. And with the housing situation in the Bay Area, which I'm sure you've all heard about, even though Vallejo is about 25 miles away from San Francisco, the wave of gentrification and escalations in housing price have really started to impact our community as well. So our program is funded by a Social Determinants of Health grant from Partnership Health Plan, and that's our local Medicaid HMO. And we've been seeing patients since September 2016. So we've been around for about 2 years now, almost 2.5, and we have about 90 patients currently enrolled in our program. So I'll say a little bit about the workflow at the clinic. So our community health worker does outreach in the community, and I'll talk a little bit about some of the venues that she uses to find patients. Our patients will have an initial appointment, which includes a comprehensive health assessment by our interdisciplinary team. It includes mental health assessment through a tool called the PSQ and an assessment of social determinants of health, the tool we use for that is called Prepare. So I will conduct a thorough health assessment, we do a mental health assessment, and then our community health worker will do an assessment of social determinants of health using that Prepare tool. At that very first visit, or even before, we arrange for enrollment in Medi-Cal for those of our patients who do, and many of them do not have health insurance when they come to see us. Most qualify for Medicaid, and we'll also enroll them in other benefit programs if needed. For example, CalFresh, which is our version of food stamps, and then we do referrals and follow-up as needed. So program outreach conducted by the community health worker, we have partnerships set up with our local sheriff's office that runs the local jails, with parole and with probation. And one really exciting thing that we've been able to get started over the past few years is that we're able now to have video conversations with prisoners who are currently in the county jails before they're released. So our community health worker is able to establish a relationship and get some sense of what their needs are going to be when they re-enter the community prior to their release, so that we can be prepared. And we found that having those video conversations beforehand really increases our rate of getting people into the clinic. They have that relationship already, and so then they're much more likely to turn to us when they need help. We also just do a lot of outreach at the Center for Positive Change, which is run by probation, at local halfway houses, substance use treatment programs. There's only one shelter in Vallejo, and our community health worker visits there frequently as well. And we also have a liaison in the emergency room who's able to direct patients to us if they have that recent history of incarceration and they show up in the emergency room without being linked to our program. So a little bit of a status report. We've found that patients in our program compared to other matched La Clinica patients have much fewer hospital visits, and we really think that's because we're doing a good job of engaging them in primary care. So 17% of transitions clinic patients versus 33% of non-transitions clinic patients, and that was in a 6-month period after about a year of the establishment of our program. And 6 months after enrollment, we're finding that many patients have improvements in their self-reported health status. Many of them have improvements in their mental health as well through engagement with our program, even though we know that the period after release from prison or jail can be a very stressful period and a difficult one for many patients with chronic mental health issues. In that 6-month period, our community health worker was able to make 77 referrals, and 91% of those were successfully accessed. And here we're talking about referrals for housing, for employment, and for access to food for patients who are having difficulty in terms of their food security. And I wanted to specifically talk a little bit about the food insecurity issue. It's something that we've really found is an issue that a lot of people face when they're coming out of prisons or jails. And research from the Transitions Clinic Network has shown that participants in our programs who experience food insecurity, not at all surprisingly, have poor health outcomes. So that's really something we realized early on in our program that we needed to address in a systemic way. So prioritizing enrollment for people to get their food stamps, the CalFresh program, and that's something we try to do even prior to their first clinic visit, if at all possible. And we also now have an on-site food pantry that's available to our program participants and also to our other clinic patients. We also have a partnership with the Contra Costa Solano Food Bank, and they actually deliver produce on site that we can distribute to our patients here. And that's a picture of our community health worker, Madonna Garcia Crawley, in front of our food pantry. All right, and so we're continually looking for ways to expand our services. Some of the things that we've implemented recently is improved screening for chronic hepatitis C. That is one of the health issues that disproportionately affects people with a history of incarceration, and we found that many of our program participants do in fact have it, and so I've started treating them on site because our area has limited access to specialty care such as gastroenterologists who can do hepatitis C treatment, so we now are able to do that in-house. We're also now able to provide medication-assisted treatment for people with a history of opiate use disorder. Many people, unfortunately, do relapse when they come out of prison or jail, and so that's something that it's important for us to have available. We've been continually working to push for access to more comprehensive mental health care services because our area has significant limitations in that department. And then we've recently implemented peer support groups for our program participants with the community health worker. So they're able to, and they have a didactic component, but they're primarily a means for us to get our patients together to discuss their experiences and provide support for each other as they navigate this transition from incarceration back into the community. Due to a lot of opiate use and injection methamphetamine use in our community, we're also looking to implement a syringe exchange program on site here at La Clinica. All right, so thank you so much, and I'll pass it on now to the next presenter.
Hi, everyone. This is Ann Sinclair from Unity Healthcare in Washington, D.C., and I'm just looking out on how many participants we have, and I'm really grateful that you all took the time today to learn about this important issue. I am speaking right into the phone, and I'm in a noisy health center, so if you hear a little bit of background noise with overhead paging, I apologize in advance. So Unity Healthcare started as Healthcare for the Homeless project in D.C. in 1985, and by 1997, the Healthcare for the Homeless project changed their name to Unity because by that point we had really expanded from only serving people experiencing homelessness to reaching out to the whole D.C. population to provide both primary care and specialty care. So as of this year, we serve 1 in 6 district residents each year. We have 9 neighborhood health centers, 2 school-based health centers, 10 homeless sites, and 1 correctional health care center, which I'll be focusing on today. So as mentioned earlier, we actually do have the contract with our Department of Corrections. DC just has 1 jail, and we have the contract to provide all health care within a jail, both mental health and medical care, since 2006. Really, we were invited to respond to a request for a proposal from the city to implement what's known as a community-oriented correctional health model. That means it's a program that fosters partnerships between a local correctional facility and a local healthcare provider so that we can have the best possible quality care both inside the facility, but then also to connect returning inmates to a local community health center when they're released. I won't get too detailed into the funding structure. Just wanted to talk a bit about our staffing model. So I'll just speak to the provider staffing because that's what I'm most familiar with. I will tell you, as you can imagine, it takes a village to provide healthcare within a jail. Nurses, medical assistants, we have an on-site phlebotomist that we contract with LabCorp, pharmacists, an entire pharmacy staff. We contract with specialists for certain in-house specialties such as podiatry, ophthalmology. We have discharge planners that are working with patients to plan for their release and try to set them up for success. And as I mentioned, we have an entire mental health staff, including psychiatrists, psychiatric nurse practitioners, and mental health clinicians. So in terms of provider staffing, we have an urgent care physician on duty 24/7. We have what's called an infirmary. So that's staffed by generally a physician assistant or a nurse practitioner, also open 24/7 and caring for our sicker inmates. We operate chronic care, which is where I work, which is basically your primary care bread and butter, diabetes, hypertension management. That's 5 days a week. And many of the providers who work in the chronic care clinic, myself included, are what we call half and half providers. So those are providers who work 2 days in the jail and the rest of the week in our community health centers. So when I meet a patient in the jail and we form a relationship just as I would in any other healthcare setting, I can say to them, hey, I've learned a lot about you in the last few weeks or months. I would love to be your provider in the community. And I think as soon as inmates hear that you're interested in following them long term, the relationship really is able to take a positive turn. I think people who have experienced incarceration, especially repeatedly and in multiple settings, are used to getting substandard care. And when they hear that you're invested for the long haul, suddenly you're able to learn what you need to learn about them and really step up and meet the needs. We also have sick call providers who are actually going on to the units, the housing units, and that's 5 days a week. We're looking to expand that to weekends. And we have intake providers. So those are providers who work late into the evening and early hours of the morning as people are being processed into the jail to immediately conduct a history and physical and promptly identify any urgent health care needs and then refer as appropriate to chronic care or other services. I mentioned discharge planning. We see chronic care patients at the time of their provider appointment so that the discharge planner can do an initial assessment determining any medical, social, or mental health needs and provide appropriate resources, including written information that they can look over while they're incarcerated and take home with them. I will mention briefly, because it came up already in the presentation, that here in DC we do have essentially a system of suspension for our Medicaid, so that when someone's incarcerated, they get an I, like the letter I, on the end of their Medicaid number. And when they are released, they are instructed how to present to the Medicaid office, show their release papers, and then hypothetically that's supposed to be reactivated within 1 week. Sometimes it happens quicker and sometimes it does not happen at all. So not a perfect system, but we've worked closely with our local Medicaid office and our administrators at Unity to try to make that as smooth a process as possible. I'll also note, just because of our roots in healthcare for the homeless, that we also have a respite facility within the Unity network. So there have been times where we have someone in the jail who's really too sick to be there or who's being released and really is going to need nursing care around the clock, and we're able to make that connection immediately to the respite. The other place that we primarily meet justice-involved individuals at Unity is the Reentry Health Center, where I'm calling in from today. So we're located within one of our community health centers called Anacostia in Southeast DC, the poorest section of the city. We serve patients residing at our 2 local halfway houses, one very large for men and one much smaller for women. Fortunately, they're easily accessible by bus, but we also have a van driver who is able to help us with our disabled clients. And the one nice thing about being in the larger health center and not just a freestanding clinic is that we can really refer patients to all these resources that our general primary care patients also have access to, such as in-house ophthalmology, dental, podiatry. We have an infectious disease provider that is seeing patients literally in the next room over from where we are. So it's really nice to say to people coming out of years and years in prison who never thought they'd be treated for Hep C, hey, here's Dr. Chavez, he's going to take care of you. We have been able to successfully treat multiple Hep C patients, both while they were in the halfway house and also when they were released. I'll just move forward here. In terms of our staffing model at the Reentry Health Center, we have one full-time case manager. She meets with every patient for intake. And much as the last provider mentioned, doing a comprehensive social intake to assess what are the needs now and what resources can we connect these folks to. We currently have 2 nurse practitioners, myself included, and we provide a total of 24 hours of care per week, and we're finding right now that that's meeting the needs of the census at each of the halfway houses. It's a little tricky over time as both the jail and the halfway house populations vary, vary over time, then it's kind of difficult to figure out what kind of a provider mix we have here, but that's what's working right now. We also have a full-time care coordinator who communicates with the patient, the medical team, with the halfway houses, and a company called NAFCare. NAFCare is essentially, we think of it as the insurance provider for all of our halfway house patients who are coming out of the federal system. So it's a company that has contracted with the FBOP, the Federal Bureau of Prisons, to oversee, to manage all of the care in the halfway houses. And so we have to work very closely with them, as you would with any other MCO, to make sure that they approve the services that we're recommending and that we can get clients what they need promptly. We also have a dedicated reentry medical assistant and nurse, which is very helpful. I think most people on this call know that there are a lot of health challenges and social challenges, just readjusting to how to talk to people, how to be in a healthcare setting that's outside of a system of institutionalization. And so our medical assistant and our nurse are just very sensitive to that, as the rest of our team is, to meet people where they are and to help them readjust to life on the outside. The other staff in the larger health center, which just operates as any other neighborhood health center would, I think are also more sensitive to the needs of our population because we're housed here. So I just wanted to show a couple quick pictures. This was when we were decorated for the holidays, and then this is the reentry team that I just mentioned. So moving on to just some barriers and hopefully a few solutions that we found along the way. During people's incarceration at the Department of Corrections here, we really find that discharge planning is key. It's difficult when you get an inmate in your office and he or she does not know when they're leaving. And unfortunately, that's kind of inherent to the system here. Many people in our jail are pretrial, waiting for a parole board hearing, et cetera. So as I'm trying to plan their care, particularly around complicated issues like cancer, it can be really challenging to just not have a sense of how long they're going to be with us. So we try to prepare people for success after release by giving them all the written information that we can so that they can connect to care in the community as soon as possible. As was mentioned earlier, the half and half providers, we can actually schedule, when we do know release dates, we can actually have appointments scheduled with us for after release so that someone can go right to my office in the jail to my office in the reentry health center, and hopefully we'll have a seamless transition of care. We still are under the jurisdiction of the Federal Bureau of Prisons for any federal inmates who are being housed in the Department of Corrections. So sometimes we have delays because of the Bureau of Prisons not wanting to pay for certain procedures. We also are challenged by transfers to other incarceration facilities, both locally, Maryland or Virginia, if someone has other charges, and the Federal Bureau of Prisons. Again, people often know that they are facing federal time, but they don't know when they're going to leave or how long they're going to be there. So it's difficult to make sure that we're trying to really be seamless in our approach to care. I will put on the next slide a resource that I find helpful called the Federal Inmate Locator, and it's just a publicly accessible website that you can log on to, enter in the patient's information, and find out which facility they've been transferred to. So I use that pretty often when I have sicker patients who really need close follow-up. I'll reach out to the next facility and make sure they're getting what they need. We also sometimes face challenges with getting records from prior incarceration facilities, and so I'll go ahead to the next slide here to show you some helpful websites that can point you in the right direction if you're trying to find Bureau of Prison medical records. If you're trying to find records from a state system, I can't really speak to that. That's, you have to go through each individual facility. But for the Federal Bureau of Prisons, they do have a procedure outlined, and these websites here will point you in the right direction. I will warn you, it is a slow process. So then kind of the next phase I think about is when people are being released, what kind of challenges do they face? So again, if someone's coming to us in the Reentry Health Center from the federal system, not from the local jail, we face the same challenges in getting records promptly. But we do use the procedure, and it works, it just takes time. we find it's really important to assess people's literacy level, not assuming that they can read the literature we're providing for health promotion or even understanding the forms we're asking them to complete. And I think that goes for the general population, but it's particularly a challenge with folks reentering. I think it's really difficult for our patients to adjust to what I would call deinstitutionalization, so getting used to coming back out, coming to appointments on time, not having an officer at their door telling them where to go and when, but really being held responsible suddenly in a very sudden way to keep appointments, to take their medicines, take their insulin, check their sugars, et cetera. And then identifying patients who are reentry patients in the first place can be challenging. Sometimes we get patients referred to us from other health centers or from our walk-in clinic who maybe came out of the state system, and they didn't have to go through the halfway house, they never went through DC jail, but they would really still be benefited by our services in reentry. So. Some challenges during the actual halfway house incarceration. I think this is actually one of the hardest places to live for my patients, perhaps even more difficult than the institutions they were coming from. I mentioned NAF Care, which has really been a nice partner for us. That's essentially the insurance company or MCO that contracts with the BOP to provide this care. We do have to work very, very closely with them. So if a patient showed up at any health center that wasn't reentry focused and had this insurance, most people don't have any idea what it is or how to work with it. So it's really important for us to coordinate closely with them and to tell patients, as long as you're in the halfway house, it benefits for you to be with us so that we can guide you through this process. And then it's difficult to retain patients after they're released from the halfway house. At that point, they feel like they're finally done with incarceration. They might move to other areas and just want to be moving along as quickly as possible and kind of sometimes wanting to leave everything behind, including any health care that they established. So I just included 2 more slides here for references. Would encourage you to read those over on your own time. And I'm going to pass things over now to Carrie Craig in Denver.
Hello. Hopefully we can get this going here. So I am Carrie Craig. I'm Director of Housing First and Assertive Community Treatment Services at the Colorado Coalition for the Homeless here in Denver. We actually started as a National Healthcare for the Homeless clinic over 30 years ago and have since morphed into something much larger than just a clinic. We actually have underneath our umbrella, Renaissance Property Management Company that does the property management for over 17 properties of our permanent supportive, the housing and affordable housing units across the Denver metro area. In addition to that, we have our integrated healthcare clinic, which is the South Street Health Center, which has primary care, behavioral health, dental, eye care, pharmacy, medication-assisted treatment. So it's really a one-stop shop sort of integrated approach to healthcare there at the South Street Health Center. So we also have, in addition to the permanent supportive housing and affordable housing properties that we have, several sober living properties, Fort Lyon, Turning Point, in addition to numerous other departments within our organization for veterans services, Native American services, vocational, community resources and outreach. We have a rural initiatives program, family support services. We also have a residential services program that operates within our Renaissance Property Management Company buildings, as well as we have our housing intake and placement team that works really closely with scattered site landlords throughout the Denver metro area and other surrounding communities. So we've got a very large array of services here at the Colorado Coalition for the Homeless, but we're focusing specifically today on the Denver Social Impact Bond Program. And I am, again, the Director of Housing First and ACT Services, and so basically we have 5 assertive community treatment teams. So the Social Impact Bond Program is actually only 2 of those teams. The overview of it is to provide housing and supportive services to 250 individuals that were experiencing homelessness in the city of Denver and surrounding areas that have been identified as the highest highest utilizers of the city's emergency services. So we're talking about, you know, police contact, detox, emergency rooms, that kind of thing. Again, just kind of a lot of it is associated with, you know, just the criminalization of homelessness. And there's a list of well over 2,000 people that actually qualify for this project, but we only had for this initial project slots for 250 individuals. It is a 5-year randomized control study that will be ending in 2021, launched in February of 2016. And the focus of the research side of it is increased housing stability and reduced jail bed days. So there's numerous partners that are involved in this project. It is a contract with the Corporation for Supportive Housing, who is hosting this in addition to the City of Denver. We have the Urban Institute, who is the research arm of the project, and then the Mental Health Center of Denver is one of the providers with the project as well. Again, enterprise, so and then we have private investors that have invested money in this project from the beginning. So ultimately, within the Housing First and Assertive Community Treatment Department here at CCH, we have 2 specialized ACT teams that will be working specifically with 170 of those highest utilizers that have been identified. It is a unique funding stream, as we've mentioned before. It's a social impact bond, and the other term that's used for it is pay for success model. So basically, they talk a little bit about why this group, and ultimately we can all, you know, kind of make assumptions about why this group. Again, as Kim mentioned earlier, the criminalization of homelessness, a lot of times, you know, these folks are just doing basic, for lack of a better term, homeless crimes, you know, different things like being intoxicated in public, definitely, you know, things like having to urinate in public, things like that that aren't necessarily crimes. I think people are sometimes misperceive this particular project as that we are serving people that are coming out of prison, and that is not necessarily the case. These are just high utilizers of the jail system and have high police contact. So it could be police contact just on, you know, the corner because they're, you know, panhandling or something like that. So, but ultimately, these 250 people do account for about 14,000 days in jail, 2,200 visits to detox, 1,500 different arrests, and 500 emergency room visits. And they talk about the yearly cost of that to taxpayers being about $29,000, and that includes court costs and all of those things associated with those emergency services. But each year, the city spends approximately $7 million on these particular 250 individuals to cover those expenses. So ultimately at CCH we have, I mentioned earlier, our housing intake and placement team and our assertive community treatment teams. We utilize both of these teams to help with this project. The housing intake and placement side of this project focuses specifically on some of the initial outreach and engagement of these folks. They have a lot of resources and connections within the community, other shelters, other you know, homeless service programs, and so they really utilize those connections in order to be able to find the individuals that we're looking for. So ultimately, someone might get randomized into the program, and they get randomized by a police contact. So they've had a police contact of some kind, and then are randomized to us. It does not necessarily mean that they've been arrested and are currently in jail. A lot of the times, it's basically just a contact, and they let us know like where the police contact occurred, and then we're able to, you know, try to go out and find the folks. So ultimately, that HIPS team focuses on finding them, helping them with vital documentation collection in order to qualify for the vouchers, getting set up with health insurance and other eligibility food stamps and, you know, other services that they might need as far as benefits are concerned. And then they do kind of the housing navigation and placement piece as well. I mentioned earlier that they do a lot of work with our landlords because all of these clients are not not centralized within our properties, within the Renaissance Property Management Company properties. We actually utilize a lot of scattered sites for this project as well. And so our housing intake and placement team really works on landlord retention and recruitment. Once they've finished kind of getting finding the clients, getting them engaged, getting that initial paperwork and vital documents collected, they pass them on to our SIB ACT team. So if anybody's familiar with the Assertive Community Treatment teams, that basically is just a multidisciplinary team of people working with a larger caseload. Usually ACT teams are focused specifically on people with dual diagnosis, mental health diagnosis, and substance use. And then we have, a whole realm of wraparound services within that team that provide the services to the clients, and those are listed there. I don't need to go into details on that. So basically, just as far as the SIB program in particular, some of the early outcomes of this project have been, we're actually, again, we have all 250 people that have been housed through the project. Mental Health Center of Denver has also housed clients through this project. They housed 80 and we housed 170. But most people housed in the project have been homeless for 3+ years. One of the longest homelessness histories was 32 years. We are seeing that some of the demographics are about 84% male, 16% female, and then after 6 months of housing, about 95% of people did not exit from the program. After 1 year, 89% of people had no exit. So it really compares to evidence-based practice for the Housing First model. This kind of indicates that when you give people housing, they actually take advantage of it and stay where they're provided housing and support services. So after being, and these are this is preliminary data because of the they're constantly doing updated annual reports on this project. But after being in the project for 1 year or more, participants spent 8 days in jail, whereas prior to that it was about 77 days in jail. So we've learned a lot of lessons through this project. We've really been focused in on trying to improve the project as we go along. Again, we're in about 2.5 years at this point, so we've got another 2.5 to go, and we want to continue to improve things for our clients as we move forward. So lessons learned are they're getting housed and they're staying housed. Again, this kind of flies in the face of that sort of stereotypical, oh, homeless people don't want to be housed, but we're finding that that absolutely is not true. When we're offering people housing, they're accepting it, and they're accepting the services that go along with it as well. We really have learned that it is really important for us to have community and interdepartmental collaborations, not only within our own organization, but within the community. We have done a lot of outreach with the Denver PD. We've done a lot of outreach with the Sheriff's Department, judges, probation and parole, and those relationships continue to be cultivated because they're just extremely important in this process. Again, really having that interdepartmental collaboration within our own organization, with the health center, with our Renaissance Property Management Company is extremely important to this project. Jail in-reach, what we found is critical to this. We, struggled a little bit with getting into the jail sometimes. They just have, strict requirements for people getting in to see inmates, and so we really had to work closely with the DPD on us being able to go into the jails to meet clients while they're there. It's really ideal that that's the opportunity. A lot of times we don't have that opportunity because they haven't been arrested and they're not in jail, but that piece is critical because then we can meet people while they're in jail, let them know about the housing resource, and then move forward from there. Again, our presence in court has been extremely successful in reducing sentences for the clients within this project. We have seen judges release clients on PR bonds, whereas normally they would have gone to jail had we not been there to describe the program and let them know that we're providing housing to folks as we move along. And the judges have been very, for the most part, very cooperative in this process. Again, a high vulnerability of a population. And vulnerability includes, you know, not only the time they've spent on the street, but also their health care. I mean, we've already, you know, seen some additional information about the chronic health conditions of folks that are experiencing homelessness, and this is extremely important. And so our South Street Health Center has been vital in that, in linking them to health care. Making sure that we have enough units to provide the clients, and ensuring that we are offering clients choice in these scenarios. Clients if they don't want to live in a certain area, we want to really value that choice and move them into an area that they want to be in, basically. We've also learned that it's really important for community building within the program. We really have to focus on, you know, social outings and building that community with these clients. And we really tried to do that prior to opening the main building for this project, because we do have 100 clients housed within our Renaissance downtown lofts. And so we really strove toward building that community beforehand. We've started different programs like getting to know your neighbor, good neighbor incentive programs within the building, in addition to just really encouraging people to be involved in the community governance board and resident councils. So that is about it for the project. So I will go ahead and turn it over to Kim so that we can facilitate any questions.
Sorry about that. I couldn't get my phone off mute. Thank you, Carrie, so much, and thank you, Ann Sinclair and Ann Sinclair and Lauren Berner for presenting today. I just wanted to close by, I don't see any questions right now, but if there are questions, we'll have a couple minutes to answer them. But I wanted to, you know, just kind of wrap up and say some things to try if you're looking at doing this work right now. You can consider or advocate for a suspension of benefits in your state or community, learn about models like Transitions Clinic Network, engage stakeholders in the justice system like from probation, parole, jail, assist with health coverage navigation, look into some data sharing between jails and health centers, and then look to your homeless system to help improve housing outcomes. In addition, we have a lot more resources about that on our website. So we have a couple questions here. Ann and Carrie, great to hear about your program, so inspiring. Thank you guys for putting this together. That's not a question, that's a compliment, so thank you for that. Thank you. Marilyn, we have a question here. How are providers able to see patients in that half-and-half setting, considering their requirements and regulatory specific requirements? I think that's for Ann Sinclair.
Yeah, so we are, I'll speak to my own position. I work for Unity Healthcare full-time. I'm a contractor for the DOC, so I have to go through all of the background checks and training for the DOC, the Department of Corrections, to work inside the jail. Once I'm inside the jail 2 days a week, I see patients in a primary care clinic on the inside, and then I can connect those patients to my health centers on the outside for after their release, and see them as I would any other community client upon release. So I hope that clarifies.
Thank you. So just to wrap up then, here's some contact information for myself and Lauren Berner. Again, we'll be sending the slides and I believe a recording along to all registered and attending folks after the webinar. This is, again, CSH's HRSA Technical Assistance website, along with a link to the publication on this topic that you learned about today. Just a closing note about HRSA National Cooperative Agreements. This webinar was sponsored by the HRSA and our National Cooperative Agreement with them, and so we thank them for their support and funding. As soon as the webinar closes, a new tab will open up in your browser, and we would really thank you a lot for filling out that quick survey. It helps monitor the success of our technical assistance and helps us direct future webinars and learning opportunities to health centers nationwide. So one more note of thanks to not only our presenters, Ann Sinclair, Ann Sinclair, and Carrie Craig, and Lauren Berner, but also to CSH's webinar mavericks, Nicole Bahina and Jennifer Yang. Thank you for helping us organize and put on this webinar today. And thanks, last but not least, thank you to all 88 attendees who came to our webinar today. Have a great day, everybody.